So I want to talk to you about how important access to public services are. And I'm going to make it personal. Okay, so I hope there are no Bobs in the room. Bob got an STI. I want you to think about why Bob got an STI. I know what the Herald Sun would say. The Herald Sun would say it's because he had too many partners or didn't use condoms. But the quick question is why? So we all have indiscretions. Bob was unlucky enough to catch something during one of those indiscretions. And the answer to the question is why? So what are the factors that influence the chance that Bob caught that infection or HIV? Because that's the most important thing. So this is a graph, and it shows the rate of infectious syphilis over the last 100 years in the UK. It would really matter when Bob had sex. So if Bob had sex in 1997, his chance of catching gonorrhea or syphilis would be extremely low. But if he had it in 1947, it would be extremely high. So that is a very strong factor. When Bob had sex really matters. And the second part of that graph is really important is what are the factors that influence the probability that those infections will be there? So clearly the war and sex workers and young men not wanting to die of virgins is important. But the overriding thing that matters in this graph is access to healthcare. You'll see it plummets with the introduction of penicillin. And while there were the Stonewall riots and the sexual revolution, and we gradually became more accepting of same-sex relationships, that paled into insignificance compared to access to healthcare. Then HIV came along, behaviour changed dramatically, and then HIV treatment got better, and gradually we will become more accepting of marriage equality. There's an equation known as the reproductive rate, and it's very important because it determines what the prevalence of sexually transmitted infections are in the population. And nothing else matters but three things in that equation. And they are the probability of transmission per sexual acts, and it's why condom vending machines are so important, the duration of infection, which is why access to healthcare is so important, and the rate of partner change. And those are the only three things that determine the difference that you saw in that earlier graph. So when you can create an environment where healthcare is accessible, you can fly into a population for A380s full of people who've got a sexually transmitted infection. Then you can land those people in a city and it doesn't matter because you don't have to worry, because your public policy has created an environment with the reproductive rates less than 1 and the infections will just disappear over time. But if you have a situation like you do in remote indigenous communities where the reproductive rate's greater than 1, you only have to introduce one person, and over time you'll get a massive epidemic. So what really matters is how you adjust the reproductive rate. Now, to give you an analogy for this, which is a bit easy to understand, imagine you're standing with a matchbox and you're throwing a match. That's your one person with an infection. If you're standing in winter in the Otways, you can throw as many matches as you like. You'll never get a bushfire started. But if you do that during February 2009, we all saw what happened. Just like the reproductive rate, where it's the rate of partner change, probability of transmission, duration, infectiousness, for bushfires, it's fuel load, moisture, wind speed, ambient temperature, and so forth. So all you have to do is create the reproductive rate that's less than 1. So let's look at some of those factors in that reproductive rate and their relative contribution to it, because one of them really stands out. Let's start with condom use and number of partners. Now, we all like having sex and we like eating. That's why there are 7 billion of us on this particular planet. Changing those behaviours is really, really hard. But changing behaviours about access to healthcare is much, much easier. And guess what? It has a much bigger effect on the prevalence of infection. So let me show you some of the data there is on changing behaviour and how hard it is. So 6,000 individuals were randomised to either 2 5-minute didactic information sessions by a clinician, or they were randomised to 2 20-minute sessions with a counsellor, sophisticated risk reduction planning, patient-motivated behaviour change and so forth. So 2 5-minute versus 2 20-minute. Look what happened. So 1 year later, the group having 2 didactic sessions had 38% of them use condoms all the time. The 2 20-minute sessions, 44% use condoms all the time. Look at the difference in the rate of sexually transmitted infections, 14.5% to 12%. So yeah, they're differences, but they're really relatively significant, really insignificant. You can increase condoms a bit through those sort of mechanisms, but when you look at a meta-analysis of that information, it only increases a little bit. So I'm not suggesting we don't try and increase condom use, but you just have to get your head around how important that is at a population level with affecting prevalence. One thing you cannot do, there have been lots of studies of this, you cannot reduce partner number. So you shouldn't try to reduce partner number. You might feel like people should, but you cannot reduce partner number at a population level. Abstinence education is a complete failure. So this is we've had a few natural experiments of this. This is teenage pregnancy on the vertical axis going up per 1,000 head population. And on the bottom axis is the abstinence education level from 0, which was no provision, 1 covered, 2 promoted and 3 stressed. And you see, as you provide more abstinence education, you get more teenage pregnancies. So access to healthcare for symptomatic sexually transmitted infections makes an enormous difference. So it's why we've tried so hard at our centre to make our services as accessible as possible for those most likely to be at risk. Now this is one of my favourite slides, and it just goes to show how access to healthcare affects gonorrhoea. It's a mathematical model, and the part A here, the rate of gonorrhoea is quite high, and they increase services by 10%. So when you increase services, the duration of infection reduces, the rate of infection falls. But when you hit 20%, you suddenly get the reproductive rate just under 1. So not only does it fall, but it falls down to much lower levels. But what's really important in slide B is that the health services that the government pays for are less once the infection's under control than it is before the infection's under control. Now, if you increase from 20% to 30% to 50%, you get rid of the infection more quickly. But ultimately, it's getting to this, to providing enough health services to get the reproductive rate to less than 1 that really matters. Now, the tragedy is that in Indigenous Aboriginal communities, who we know don't have more partners than in the rest of the population, who we know don't use condoms less, have rates of gonorrhoea that are 100-fold higher than the rest of the population. That's because the reproductive rate in those populations is greater than 1, but the reproductive rate in non-Indigenous populations in the capital cities is less than 1. So you can see this is, and access to healthcare is really complicated. It's not as simple as just putting a health service there. It's about educating people about recognising the symptoms of what is a sexually transmitted infection and making it safe and confidential for people to go there. But even asymptomatic screening can make a substantial difference. I think I'm fair to say that in the developed world, people look at these with some surprise. I think Australia is doing incredibly well. This is some data from Eric Chow. It's in press at the moment. And this is the syphilis testing in Australia in gay men with HIV. And it's gone up a lot, from about 3,000 tests up to about 6,000 tests. So it's sort of doubled, and that's because places like our centre have made access to health services much easier, but also because we've introduced syphilis testing with every viral load. So you actually have to take the syphilis test off a request form, it automatically appears on. Well, look and see what happens when you do that. So this is syphilis diagnoses. Early latent is blue, secondary is the green, and primary is the red. So we go from, generally syphilis goes from primary through a latent period to secondary and then on to another latent period. And what's happened as a result of that testing is that you've seen no change in primary because it occurs within the first few weeks or so, so you wouldn't expect that to change. you've seen a reduction in secondary syphilis and an increase in latent. So people are getting tested more frequently, they're getting diagnosed before they proceed to secondary syphilis, and secondary syphilis is one of the most infectious parts of the syphilis round. So this asymptomatic testing is causing a reduction in the duration of infections, but also a reduction in the infectiousness of cases. The last thing I want to make a point about is inequality. Inequality matters a huge amount. It doesn't matter so much in countries where healthcare is accessible and not dependent on your income, but it matters a lot in countries where access to healthcare is not necessarily a human right, but is seen more as a privilege. And of course, people don't choose to have inaccessible healthcare. So this is the US HIV infection rate by race. Okay, so we have here white in light blue, dark blue is black, African American and Hispanic. And you'll see that the rate of HIV infection is 1.7 in white and 30 in black Americans. They don't have more partners. They don't use condoms differently. What happens is the people with whom they have sex have less access to healthcare. They get their HIV treated less quickly. They become undetectable and non-transmissible. They have higher STI rates, and all that translates into a higher reproductive rate than you've seen others. They're not having more sexual partners. They're not using condoms differently. Remember Bob at the start, they exist in a population that has less access to healthcare. And this unfortunately translates to all populations. This US HIV infection rate in gay men who have sex with men. White has an odds ratio of 1, black African Americans 6 times higher, and Hispanic it's 3.5 times higher. Again, this is not more sexual partners. It's not using condoms differently. It's about less access to pre-exposure prophylaxis. It's about higher STI rates, and it's about less treatment of people who have HIV infection or may not know they've got HIV infection. It's all about access to healthcare making very big differences to the population prevalence of these infections. And unfortunately, this translates to a very disturbing lifetime risk of a gay man in America catching HIV. So if he's a white man, he has a 9% lifetime risk of catching HIV. If he's Hispanic, it's 25%. And if he's black, it's 50%. No more partners, no more condom use. It's all about access to healthcare. That's why access to healthcare, particularly for transmissible infections, is so important. There's other things that matter too. There's some biological differences that matter. So let's compare men who have sex with men to heterosexuals. And let's talk about gonorrhea. So if you look at men who have sex with men, less than 50% of cases of gonorrhea in gay men occurs in the urethra. When the urethra gets infected with gonorrhea, within 2 days, within about a week or so, they get symptoms. The mean duration of someone with urethral gonorrhea mean duration of symptoms of someone coming to our service is about 1 to 2 days. So they come and get treatment immediately and it's over. But in gay men, 50% of infections occur in the throat or the anus where there's no symptomatic infection. So they don't know they've got it. So it won't be 1 or 2 days, it might be 3 months or longer. If you compare that to heterosexuals, when heterosexuals have sex, the urethra is almost always involved and you get symptoms occurring, part notification is higher, and even in women symptoms are much more common. And this slides back to front, but essentially it creates an environment where the duration of infection is very high in gay men and very low in heterosexuals. So the duration of symptoms in the male urethra is about 2 days and about 90% is symptomatic, compared to the MSM who have it in the throat, where the mean duration of infection is about 90 days and very few are symptomatic. So this is being driven by the biology of the people having sex with one another. So we look and we ask the question, why is chlamydia not that much more common in gay men than heterosexuals? Why are genital warts not that much more common in gay men than heterosexuals? But gonorrhea is enormously different between those two groups. This is not due to number of partners, it's not due to condom use, it's simply due to some biological difference in the way that these two groups of individuals have sex and the sites that are infected. So I'm going to put to you that government policy has a much more powerful effect on HIV and STI incidence than anything else. And that is about access to STI testing, it's about access to treatment, it's about partner notification services, it's about access to primary health care. Much more important than individual choice about condoms and partner number. Public policy actually really matters. It matters in lots of different things. It matters for the spread of HIV in people who use injecting drugs. It matters because it creates unequal STI rates in community because they have poor access to health care. And of course it translates into other things like obesity as well, with poor public policy. So access to health care is critical. Why did Bob get an STI? He might have been unlucky enough to live in the 1940s. He may be unlucky to be an African American and live in the United States and not have accessible health services. There are some features, the anatomical features of sex between different groups that influence the prevalence of infection. Community acceptance has something to deal with it. And lastly, and relatively unimportantly, it's personal practices that matter. And you've got to remember that we're programmed and it plays a relatively small role in the whole business. So thank you very much for your attention.